Hello dear students, welcome to another very important topic from the practical exam point of view, and it is very important for frequently asked questions in viva also, that is examination of year. So in the last video we discussed how uh, we will take the history of uh, ear problems or ear diseases, and now we will discuss that how we will examine the ear. Okay, so let's start. Okay, so as we all know, ear can be divided into three parts: external ear, middle ear, and inner ear. So we will examine mainly the external and middle ear, and at last for the inner ear we have certain tests as well. So first of all, we will start with external ear. So external ear has three parts: pinna, external auditory canal, and tympanic membrane. Okay, so pinna is also known as auricle. So how we will examine the pinna? Again, there are various regions such as pre-auricular region or post-auricular region. Okay, so here auricle is the another name of pinna. So how we will examine the pre-auricular region? We will look for any kind of sinus, any kind of swelling. So swelling can be in form of abscess or lymphadenopathy, or it can be a parotid swelling as well, or any kind of cyst such as sebaceous cyst or dermoid cyst as well. And also we will look for the scar. This scar will be due to the surgery. It can be a parotidectomy or any kind of preauricular sinus surgery, or the removal of preauricular skin tag. Okay, what is the skin tag? Basically, it is the presence of a skin or cartilage. It will always be present along the line joining from the tragus of ear to the angle of mouth. Okay, so these are the important points regarding the examination of preauricular region. Next is the pinna, that is the proper auricle, we can say. We will look for the site of pinna, size of the pinna, and position of the pinna. What is the normal position of pinna? We will draw a horizontal line starting from the eyebrows, and it should coincide with the upper margin of pinna. And similarly, we have to draw a horizontal line from the nostril as well, opening of nose, and it should coincide with the lower border of the pinna. So if pinna lies here, it is a considered as normal position. Size can be small or large. It can be categorized as microtia or macrotia. In the post-auricular region, we have to look for the post-auricular groove. It can be normal or extra deepened, or it can be obliterated also. It will be obliterated in cases of swelling, like such as mastoid abscess, sebaceous cyst, dermoid cyst, or any kind of lymphadenopathy due to furunculosis. And we can also look for the scar in the post-auricular region that indicates basically the mastoid surgery or ear surgery. And the scar is of typical famous incision that is known as Wild's incision. Coming to the examination of external auditory canal, there is nothing much in the examination of EAC. Basically, it is a bony cartilaginous tube which has the outer one-third part as cartilage and inner two-third part as bony part. So we will look for the content of the EAC. Basically, there can be discharge that indicates the acute separative otitis media or chronic separative otitis media. There can be wax due to secretion of ceruminous glands, and also there can be a swelling inside the EAC that can be furuncle, that is infection of hair follicles, and there can be EAC polyp or granulations. There can be bony outgrowths or bony benign lesions as well, known as osteoma or exostosis. Okay, so now coming to the tympanic membrane. For the examination of tympanic membrane, we have to look for the various things such as color of tympanic membrane. Normally it is pearly gray, or in some books it is also written as pearly white. And there should be a cone of light present in the anterior inferior quadrant, and it is situated at the 55-degree angulation with the floor of external auditory canal. There should be visible handle of malleus and impression of lateral process of malleus. There also should be impression of incudostapedial joint and opening of eustachian tube. Impression should also be visible behind the intact tympanic membrane. There will be anterior and posterior malleolar folds. Mobility can be assessed by three methods: Valsalva maneuver, Toynbee's maneuver, and with the help of Siegel's pneumatic speculum. Now coming to the perforation of tympanic membrane, there are basically four sites, or we can also divide the whole tympanic membrane into four quadrants: anterior inferior, anterior superior, posterior inferior, and posterior superior. So the shape of perforation can be round or circular, and it can also be in a kidney shape. Now we will look for the margins of perforation. It will be congested in case of acute separately otitis media, and the margins will be thickened in case of chronic separately otitis media because of the chronicity of the lesion. And if the margins are irregular, it will be seen more commonly in the traumatic perforation. Also, we look for the medullary mucosa. It will be congested, or it can be edematous, or can be there presence of granulation tissues as well in case of aticointral disease. Now, what are the types of perforation? Basically, it can be divided into three types: central, marginal, and attic. What is a central perforation? In which all the quadrants of perforation are surrounded by the remaining pars tensa. That is known as central perforation. And in the marginal perforation, the three quadrants will surround the edges of perforation, but the one quadrant is surrounded by the tympanic bone. Okay, that is the marginal perforation. It is most commonly seen in the posterior superior quadrant. Next is the attic perforation. It is seen in the pars flaccida of the tympanic membrane. Coming to the types of central perforation, it can be divided into basically five types. First is small central perforation, in which there is only one quadrant or less than 25% of pars tensa is involved. Next is the medium perforation, in which more than one quadrant or less than two quadrants are involved. And third is the large perforation, in which more than two quadrants or less than three quadrants are involved. And next is the subtotal perforation, in which more than three quadrant or approximately more than 75% of pars tensa is involved, or the perforation is only surrounded by the tympanic annulus. Okay, that will be categorized as subtotal perforation. Next is the total perforation, in which the total tympanic membrane is absent, whole pars tensa, pars flaccida, and tympanic annulus as well. All are the absent. That will be categorized as total perforation. It is seen more commonly in the necrotizing otitis media. Coming to the few important tests that are part of the routine year examination. The first is the tragal sign. So basically, what is the tragal sign? On pressing the tragus inward, there will be presence of pain and tenderness. And if the tragal sign is positive, it indicates otitis externa. And if there is no tenderness or pain, the tragal sign will be negative. Next is the three finger test. In this, basically, we will examine the ear with the help of three fingers. One is middle finger, second is the index finger, third is the thumb. So we will place the middle finger on the Simba concha. If the tenderness is present, it indicates infection of mastoid antrum. And if we place the index finger on the posterior border of mastoid cortex, if the tenderness is present, it will indicate most likely the thrombophlebitis of mastoid emissary veins. And if we place the thumb on the mastoid tip and the tenderness is present, it will indicate the mastoid tip cell infection. So that is the importance of three finger test. Next is the fistula test. So in this, basically what we do, that with the help of Siegel's pneumatic speculum, or by the alternate pressing and releasing the tragus, or with the help of a speculum, we will look for the nystagmus in the eye and ask the patient for the symptoms of vertigo. What is the inference of the test? Basically, we have to look for the nystagmus when patient tells that he or she feels the symptoms of vertigo, such as dizziness. So during the positive pressure, with the pneumatic speculum or by pressing the tragus inwards, basically the nystagmus will be present towards the side of lesion. While during the negative pressure, nystagmus will be seen towards the opposite side of lesion. What is the positive fistula test? In which the nystagmus is present? So it indicates the presence of fistula in the lateral semicircular canal. It will be seen most commonly in the chronic separately otitis media. The variant will be aticointral, and it can also be seen in case of accidental arteriogenic injury to the to the semicircular canal, and also in cases of temporal bone fracture. So basically, what is a negative fistula test? In this, there will be no fistula present. So there are again few variations of the negative fistula test. One is false negative fistula test. It will be seen in case of dead labyrinth, and false positive fistula test. It will be seen in cases of early Meniere's disease and congenital syphilis. So basically, what is false positive fistula test? There is no fistula as such, but the symptoms of vertigo will be there and nystagmus will be present. So basically, in cases of early Meniere's disease, the enlarged saccule will press against the footplate of stapes. That is known as also Hannibal sign. It is a very important sign that is named as Hannibal sign. Also, it is seen in cases of Tullio phenomena. That is basically the vertigo will be present due to noise. Okay, so now coming to the tuning fork test. Basically, it is done to identify the type of hearing loss and also the degree of hearing loss. So there are various parts of the tuning fork, like such as prongs, base, stem, shoulder, etc. Okay, so the prongs should strike against a rubber pad, or we can also strike them at a bony prominence at the junction of upper one third and lower two third of the stem of tuning fork. Ideal tuning fork for the tuning fork test which is used is of 512 Hz. Why? Because the vibration falls within the speech frequency range, that is 500 to 3500 Hz, and also it never produces the overtones. That is why it is preferred. Now we will discuss each one of them one by one. First is Rennie's test. In this, the vibrating tuning fork is placed over the mastoid of the patient, and the patient is instructed to raise the finger when he or she has stopped the hearing. Then also we can place the tuning fork vertically 2 cm away from the external auditory canal when the patient has stopped hearing, and then we will ask the patient that if he or she is hearing the tuning fork's vibration in front of the external auditory canal. Okay, so coming to the interpretation of Rennie's test, the positive Rennie's test will be called if the air conduction is more than bone conduction, and negative Rennie's test will be called if bone conduction is better than air conduction. Now the false negative Rennie's test will be seen in cases of unilateral sensory neural hearing loss, and infinitely positive Rennie's will be seen in case of severe sensory neural hearing loss. Next is the Weber's test. It is done basically for the bone conduction, and it tests both ears simultaneously. So basically we look for the better hearing cochlea among the two ears. In this, the tuning fork placed over the any midline bony prominence. It can be glabella, it can be vertex, or it can also be occipital protuberance. And we'll ask the patient that in which ear, right or left, vibration is heard or felt better, or if equal in both ears. Okay, so what is the inference of Weber's test? It will be called as normal if the vibration is equally heard or felt in both ears, or if it is felt in midline. And it will be called as conductive hearing loss if the Weber's test is lateralized towards the worst ear or the diseased ear, and it will be labeled as sensory neural hearing loss if vibrations are lateralized towards the better ear or normal hearing ear. That is the inference of Weber's test. Now coming to the absolute bone conduction test. In this, basically we will be comparing the bone conduction of patient with the examiner, assuming the examiner's hearing level is normal. So how we will perform this test? Basically we will occlude the EC, and tuning fork will be placed over the mastoid region, and ask the patient to raise the finger when person stops hearing. Okay, so when the patient raised the finger, then tuning fork placed over the mastoid region of the examiner to check if the examiner is still hearing or not. What is the inference of absolute bone conduction? It will be labeled as normal if bone conduction equally heard in both of them, that is for the patient and examiner as well, and it will be labeled as sensory neural hearing loss if bone conduction is reduced in case of examiners, and it will be labeled as conductive hearing loss if there will be normal or lengthened bone conduction, that will be labeled as conductive hearing loss. Now coming to the Schwabeck test, it is same as absolute bone conduction test. The only change is here that external auditory canal is not occluded, while in case of absolute bone conduction, the external auditory canal was occluded. Okay, coming to the Gillies test. In this, the tuning fork is placed over the mastoid region, and at the same time, external auditory canal pressure is raised with the help of pneumatic speculum. Now, what we have to do basically, we have to ask the patient for the reduced hearing of, or if there is no any change. What is the inference? In case of normal ear and in case of sensory neural hearing loss, the sound will be reduced, while in case of conductive hearing loss, it will be unchanged. And now coming to the Binks test. In this, the tuning fork placed over the mastoid, external auditory canal occluded by pressing tragus inward, and we will ask the patient whether he hears better or if there is no any change. What is the inference of the Binks test? In case of normal or sensory neural hearing loss, there will be increased hearing. Mind it, there will be increased hearing. And in case of conductive hearing loss, there will not be any change. That is the inference of Binks. Okay, now coming to the what are the levels of hearing loss? It can be categorized into following categories. Normal can be labeled as hearing loss up to 25 decibel, and mild can be categorized from the 26 to 40 decibel, and moderate can be categorized from the 41 to 55 decibel, moderately severe from 56 to 70 decibel, severe will be 71 to 90 decibel, profound hearing loss will be from 91 to 99 decibel, and the total hearing loss will be labeled beyond 100 decibel. Okay, so these are the classification of hearing loss. The confirmatory test will always be the pure tone audiogram. So that was all about the examination of ear, there are few more topics left related to this that we will discuss separately. That is the examination of facial nerve and the vestibular function tests. Okay, so we will deal with them separately. So this was all the basics regarding the examination of ear. Keep enjoying, keep learning, and follow this channel for more such contents. Thank you so much.